I started my career in the States between Philadelphia and New York. Then they kicked me out and I moved to the UK, where I spent most of my training and my working career, especially at Imperial College between St Mary's Hospital and Charing Cross. During my training, I developed a special interest in a different field altogether, which is rhinology, where it's a field that takes care of noses and sinuses, and also facial plastics with rhinoplasties and other surgical management of skin tumors of the face. But I never abandoned completely otology, even because, I guess because what happened to my father when he was a little child. He died at the age of 102 2 months ago. So when he was a little child, surgery and let alone antibiotics were not there yet. But surgery was in his kind of infancy still. So he had an abscess in the back of his ear, almost died by the age of 5. And that left him with not a great hearing on that side. So I was also a bit kind of sensitive to people that had hearing problems. And when I moved here to Gibraltar 2.5 years ago, I was asked to lead the ear clinic, which I did. And so for the last 3 years, I've been seeing mostly patients with the ear problem. So probably I have to invent a new term, not a rhinologist or otologist, but a rhinotologist. In other words, somebody who has an interest in both ears and noses. Let's see if I can continue to use this. Okay, so we have a lot of grounds to cover, and this is the index of the things we're going to talk about. I'll give you a little bit of information and numbers on statistical numbers about the hearing loss and how this has an impact in the world and individually. I'll try to explain to you how the hearing mechanism works, and then we'll touch a bit on the different causes and different types of hearing loss. And then we'll touch on pediatric causes and adult causes of hearing loss. And finally, we'll look at the horizon of research, what's available after, describing a little bit about what is available on hearing rehabilitation here. We also have in the audience Eugenio Mendieta and Carmen from OIGA, where are they? Oh, there they are. From OIGA Hearing Center in the ICC, and they will be available at the end of the talk. If anybody has some question regarding hearing aids, they will have some on display. They are here on this little table. So he will be much more qualified than me to talk to you about hearing aids. I'll try my best in a couple of slides, but I'm just a doctor. He's a specialist, okay? So he will be able to give you more information. Right, let's start the journey, okay? So the World Health Organization states that there are at least 500 million people that suffer from hearing problems. And this number is predicted to double in the next few years. It is, as some of you know, it remains an undetected disability, commonly for quite a few years, before patients that have this problem eventually will seek medical attention. It is ranked as the hearing loss is ranked as the fourth hearing disability, being aging and noise exposure the most common risk factors. Oops. Right. It is the fourth disability, but it's the most common sensory handicap. We have 5 senses: the eye, the vision, the sense of smell, taste, touch, and hearing, which is not the last. 1 over 3 people over the age of 60 will have a significant degree of hearing loss, and 1 over 1,000 child will be born with a severe hearing loss, either affecting one ear or both ears. That number doubles in by the age of 3. Can you hear me in the back? Yeah? Okay, please let me know if you can't. So as most of you know, it's a neglected condition that can have a major impact on the social, mental and physical health. You'll be surprised to know, some of you will be surprised to know, that it takes quite a long time before somebody who has a hearing loss will eventually try to find a solution to it. So 7 to 10 years often is what is required. It's the interval that of time that is required for somebody to seek medical attention. Furthermore, some of the patients that eventually go to see their GP are not referred right away to be assessed by an audiologist or by an ENT doctor, and therefore the management is delayed even further. Also interesting number is that 80% of the people that could use hearing aids or have hearing aids and really don't use them for various reasons, being vanity one of those, because some people don't like to be seen wearing a hearing aid. It may sound strange, but this is not an uncommon situation. And because of that, the industry, and Carmen and Eugenio will be able to give you some more information about this, the industry has been receptive and has come up with a solution, many different solutions of different types of hearing aids, some of which are hidden inside the ear canal, so are hardly visible. Now, how is the hearing tested? Now, this is a standard diagram of a hearing test. It may look complicated, but I'll try to explain it to you. It shouldn't be that complicated after I explain that to you. Well, conventionally, hearing loss, there are 4 types of degree of hearing loss: mild, moderate, severe, and profound. Now, if you look at the top of the diagram, there are 2 kind of lines. Okay, one is blue and one is red. The red lines refers to the right ear that is being tested, and the blue line, the left ear that is being tested. This diagram represents a normal hearing. Why? Because conventionally, everything that's at the level of 20 and above is considered normal. What is that 20 number? If you look on the left side of the diagram, there's a vertical column of numbers that start from -10 and goes all the way down to 120. And this is the intensity of sound expressed in decibel. The top column, horizontal column, depicts the frequency of sound, in other words, the pitches of sound, from very low to very high. So patients, when they do have a hearing test, they are exposed to simple sounds at different volumes and frequencies. Now, this patient has a normal hearing because between the level 10 and 20, most of the time this patient was able to detect the sound. Between 10 and 20, just to give you an idea, there is whispering sounds. If I was having a conversation face to face, probably I would be talking with a volume around 30 and 40, so higher volume. Now, conventionally, we said the degrees are 4: mild, moderate, severe, and profound. Now, you may think that moderate, which is between 40 and 70 decibel, is not really a moderate degree of hearing loss, and I explain to you why in the next slide. This slide is very similar diagram that you saw in the previous slide, but there is on the center here, there is this shape which looks like a banana, which comprises most of the sounds that we use in a normal conversation. And therefore, that banana resembles the speech, the normal speech that we have during daily life, with high volumes. For example, this barking dog will have an intensity of sound around 70 decibel. A child will be second on that list, around 60, although some parents probably will disagree with that and actually might think that that child probably resembles a much higher sound, like a machinery or a Boeing down there, okay? So imagine that, just keep in mind this shape and this number 60 decibel, okay? Now this is a diagram of someone who has a right hearing loss down to 60 decibel, just below the banana. So this person here will be completely cut off from any normal conversation. He will perhaps get a little tiny idea what what people are telling him, but most of the sounds he or she will not be able to detect. And this is considered a moderate to severe hearing loss. So you can appreciate that this is a clear handicap, because most of the time this person will not be able to understand what people are telling him and will not be able to discriminate the words around him. Now, most of you that have a hearing loss will probably know by heart this slide, because there will be an impact, significant impact on speech development. And imagine a child that cannot hear will not be able to develop his language, his education, and will have significant impact on the social and mental development, let alone the overall well-being. It also will have a significant impact on the, generally speaking, on adults as well. May increase the feelings of loneliness, isolation, frustration, especially among elderly people. Imagine during COVID, when we had to be in a lockdown. So if you had a hearing loss, that would have been even more of a problem. And wearing a mask was also an additional handicap, because most people that have a significant degree of hearing loss consciously or subconsciously do some type of lip reading. It's a cause causes much higher rates of unemployment, and has recently been linked with neurocognitive disorders such as dementia. I have a slide that explains that. Oops. So, like with many other medical conditions, prevention is the key, because an early prevention may lead and will lead in most circumstances to a management to solve, to help people with hearing loss. Nearly 60% of hearing loss in children is due to preventable or treatable causes. And this is also true in the vast majority of the causes of hearing loss in adults, apart from aging. In fact, research has focused mostly, and we'll talk about this later, on presbycusis, which is hearing loss that occurs in older people. In those, in that age group, and I'll show you several slides, the little precious cells that help us to hear are not working very well anymore, and some of them are destroyed. So how can prevention be achieved? Well, there are different strategies from early stages of life, like immunization, good maternal and child care practices, genetic counseling when required, treatment of common ear diseases, and implementation of the regulation that are already in place have been already in place over the last 15-20 years regarding occupational noise exposure and chemical exposure as well. Reduction of the noise exposure in recreational environment and settings will also be quite useful, but as you know, if you listen to a rock concert, or you have in a stadium, then obviously you'll be exposed to very loud noises. and sometimes it's difficult to find a good balance between social events and hearing protection. Now, let me try to explain to you how the sound eventually reaches the brain. So the ears is made up of three parts. The external ear, which is this part here made by the auricle, that's what is called this part of the ear, and the ear canal. The middle ear is this bit here, which is made of the eardrum, three little bones that we also call the ossicular chain, which I call, if you're interested and curious to know, malleus, incus, and stapes. The one I would like you to focus more is the stapes, which looks like a stirrup, which is the bone that, so to speak, articulates with a funny shaped organ here, which is the inner ear. It has a shape of a snail. It's called also the cochlea in scientific terms, but we will, from now on, we'll call it a snail. So that little stirrup articulates with the snail. Eventually then, the snail brings the sound to the brain through a nerve, which is called the cochlear nerve. Now let's see how the sound waves eventually reaches the brain. Excuse me. So sound enters the canal, puts into vibration the eardrum, which in turn puts in vibration the little bones that in turn will stimulate the snail to send inputs into the brain. How does it do that? Well, the stirrup moves into the snail, and the spirals of the snail are filled with fluid. So the sound gets in, imagine like a big wave that eventually moves the little cells containing the snail. Now the tip of the cells that are embedded in that liquid have little hairs, little filaments. In fact, they are called hair cells. So the sound wave moves these filaments, and this triggers firing of these cells, which are neurons, that eventually send the input, the neural input into the brain. And the brain then processes this sound and makes sense of them. Is that clear so far? Good. Okay. Now this is an electronic, it's an electronic microscope picture of the snail. So you can see the nice arrangement of all the cells that we have. And those of you that came to my other talk probably will remember, because I asked this question, do you know how many cells we have in the ear? Anybody has an answer? How many of these so-called hair cells we have in the ear? I'll tell you that there are 40 million. There are 40 millions in the nose and 15,000 only in the ear. So a huge difference. So that tells you that those cells are very precious and we need to protect them. Even because, like any other brain tissue, once they are gone, they are gone. They won't come back to life. They won't be regenerated. So there are two types of hair cells. I won't go too much into details, but basically one type of cell has the role to amplify sound, and the other one has the role to convey the sound and relay the sounds to the brain. Oops. Okay. Now you will have thought there is a musical break and a piano will come out. Oh, we have a piano actually there. And somebody will be offering some cocktails, but no, that's not the case. The reason why I put up this beautiful Steinway piano is because in my mind the representation of the snail with all these little hair cells in my mind resembles the keyboard. If you think about a keyboard, the keyboard is made of keynotes, and they go from very low tone to very high frequency sounds. Now, if you think about the piano, the keyboard, connected to the ear, you will have something like this. All right? So, very low frequency sounds and very high frequency sound. Well, it is very similar. This is what happens, very similar to what happens into the snail, because the cells that I showed you before, that are very close to the stirrup bone, remember the stirrup bone? Those are the ones that are specifically picking up high frequency sounds. As we go towards the center of the snail, which is called the apex, there will be cells that will, whose role is to pick up low frequency sounds. So progressively we go from high frequency sounds, cell detector, so to speak, to very low frequency. Now, this is a typical hearing test of someone with age-related hearing loss. Why can we say that? Well, because the high frequency cells, the one close to the stirrup, are more vulnerable for different reasons. One of which is because probably they are smaller. And therefore they are the first one to go. As I said, they cannot regenerate. They cannot be replaced. So this is a typical sloping down hearing loss at the mid-high frequencies. These are the cells that are more vulnerable. And eventually with time, this doesn't happen overnight. This is a gradual progressive hearing loss that most people over the age of 60 will have some degree of this. Even if you test the hearing of a 15-year-old child compared to a 25 and 30-year-old adult, there will be some differences in the high frequencies in a quite good number of those individuals. So it's a process that starts relatively at a young age, obviously with individual variations, especially if there has been, for example, history of noise exposure or ear diseases. But it is a physiological process, and this happens with all the other senses, with the vision, etc., etc. Now, there are many causes of hearing loss, but the most common ones are aging and occupational noise exposure. But besides those, there are also other common causes such as infection, ear infections, genetic and hereditary conditions. Systemic disease means diseases that can affect the whole body, such as diabetes, medicine that are toxic to the ears, trauma to the head, rare benign tumors, and other conditions. Now, some of those causes can affect all stages of life, such as wax, noise, head trauma, hereditary condition, toxic drugs, and infection. Others are more specific to a certain age group. For example, in a congenital condition that can affect the fetus, such as infection during pregnancy, gestational diabetes, which is diabetes induced by pregnancy, can also be a cause of hearing loss, as well as family history of hearing impairment, low birth weight, and babies that are born preterm. A typical cause of hearing loss in childhood is glue ear. Probably all of you have heard about this. It's not that common in places like this where there's a very nice climate, but if you live in the UK, for example, where I worked for 10 years, there are much more glue ears there than there is here, just because the weather is different. And I will show you a slide about glue ear later on. And then lastly, during adulthood and in the elderly group, age-related hearing loss, as we said, ear infection, otosclerosis, which is an hereditary condition, is relatively common, I have to say, and then chronic ear infection that eventually can affect the hearing. Now there are two types of hearing loss. One is called sensorineural hearing loss, which affects the inner ear, the snail, and the other one is called the conductive hearing loss, which is due to diseases of the ear canal or of the middle ear, where the little bones are harbored. And if I'm not mistaken, then the next slide shows those two different types of hearing loss. This is already familiar to you. This is somebody with a age-related hearing loss, and it's called sensorineural hearing loss. It's affecting the snail. On the other side, there is depicted a conductive hearing loss. Why can we say that? Well, because there are two lines here. These are these two lines of the left ear, okay? So there's a gap between these two lines. What do they represent? Well, the top line represents the potential hearing. If there was no issues either within the ear canal or within the little bones that transmit the sound. The lower line is the actual hearing, is what the patient is perceiving. So in this case has again, conventionally speaking, is a moderate degree of hearing loss. Why is that? It's because the problem doesn't lie on the snail. If I was to bypass the canal and the middle ear and stimulate directly the snail, I will get this line. But in real life, the patient hears at this level. Does it make sense? Yes? No? Yes? No?
Can you do it again?
Yeah, so basically, if I go back to the previous previous slide. Okay. This is the snail, okay? Right? Which is like the processor of sounds. This is the ear canal, and this is what is called middle ear, where these little three bones are located, okay? Now, if I have a problem here, let's say a simple thing, a lot of wax, the sound wave will find it difficult to travel freely towards the middle ear because there is wax, okay? So if I was to introduce the sound here, and you had all this wax, you won't be able to hear very well. You won't have a huge degree of hearing loss, but some. But if I was to bypass these two and stimulate directly the snail, your hearing will be fine. Okay? And that's exactly what is done with a conventional hearing test. First, they introduce the sound here, and then if there is any abnormality in that test, they will put a microphone in the back on the bone, so we'll bypass the ear canal and the middle ear and stimulate directly the snail. Okay? So if we go again back to the other, this is temperamental, okay? So this is the snail that we are stimulated. It gives a normal result. And this is the sound that travels through the ear canal and through the middle ear before reaching the snail. So this wave is being affected by whatever disease is in the canal or the middle ear. Is that clear now? Okay? Please do stop me if because to me it's clear, but it may not be for you. I'll try to make it as simple as possible, but not always I succeed in that. Okay, so we were talking about the different type of hearing loss. So different causes can result on one type of hearing loss, either a conductive or sensory, or can cause both. For example, genetic disorders, a child can be born with a mixed degree of hearing loss, both conductive or sensory. Narrow hearing loss. I had trauma. Imagine if you have a fracture line that crosses the snail and the little bones, you will have a mixed hearing loss. So, what are the symptoms? Well, I can ask Edgar give you a lecture on the symptoms of Tony. Basically, when someone has a hearing loss, correct me if I'm wrong, loses two things, the volume and the clarity. Is that correct? Is that correct? You all agree with that? So obviously the worse is the hearing, the more these two things are affected, overall decrease in volume and clarity, discrimination of the words or the sounds. And this therefore will have a cascade of repercussions, conversational difficult to be understood, particularly with significant background noises in restaurants, pubs, crowded offices, etc., etc. And then speech will sound mumbled, slurred. Certain sounds will be more difficult to be heard, or will be difficult to make sense, such as the one that contains high frequency sound, S or TH, so hard to distinguish. Interestingly, ordinary noises sometimes are perceived as too loud, and loud noises as uncomfortable or painful. This is called hyperacusis. This is something that can also occur in people that don't have hearing loss, or that a conventional hearing test has shown normal results. Tinnitus is also something that is quite common in patients with hearing loss, and this may occur in one or both ears. Although also people that have normal hearing can have tinnitus. So in the theory behind tinnitus in patients that have a hearing loss, the most followed theory is that it's a extra brain activity, as if the brain is trying to make up of the lost sound by introducing himself or itself extra sound. So it's a phantom sound that the brain is producing. I think that the talk on tinnitus is still on YouTube, so if you're interested you can just put guitar and tinnitus and you'll find it. So, as I mentioned before earlier, that identification is a key for early management. And how is this done? Well, in children nowadays, most of the developed countries have introduced neonatal hearing screening, which is done, and I have a couple slides on this later, is done within the first few months of life. But not only children should be screened, but also other other groups, like people exposed to occupational noise or chemicals, and people that are receiving drugs that are toxic to the ear, such as the one used for cancer treatment, and also all the adults. Most of these people will not be tested, sadly, even the ones that are receiving chemotherapeutic drugs. They will be tested only if the patient will complain really of deterioration of the hearing. If you want to test your hearing, is a very rough way. For a more sophisticated way, you have to go and see an audiologist, or you have to go and see Eugenio and Carmen. But there is different apps that you can download easily, and you can check your basic hearing level. I just put here the app from the World Health Organization, which is called Hear Who, and in 5 minutes you can test your hearing. I wouldn't just rely on that, but it will give a rough idea of your hearing level. So as I said, we'll talk a little bit about pediatric hearing loss, 1 in 1,000, and some studies show that it's probably more than 1 in 1,000. They are born with a severe hearing impairment. That number increases to 1 in 100 babies who have spent more than 48 hours in intensive care, whatever the reason was. And most of these babies are born into families with no clear history of hearing loss. Quite a good number of infants that are born with hearing loss are, the causes are genetically related with genes mutation, for example. So infections that affect the pregnancy, such as cytomegalovirus, herpes and rubella infections, diabetes, etc., are quite common conditions. Fetal distress with reduced level of oxygen has also been linked with hearing loss. High level of bilirubin, which are found in jaundice, so severe jaundice. 90% of patients with kids, little babies with high degree of bilirubin will have, 90% will have some degree of hearing loss. Low birth weight and preterm, as I mentioned before, are also risk factors. Now, the neonatal hearing screening is quite important because early detection will lead to early intervention. And this is fundamental because a child that doesn't hear, doesn't develop his or her language, it will have a significant issue during life regarding education, communication, etc., etc. Neonatal, I just want to go into much details, but there are two tests that are done. Mainly one, the first one, which basically tests the ear response to sound. These two tests don't require the participation of the infant, even because it's too small, can really help. So these are passive tests. The first test introduces sound into the ear, and the ear will respond with vibration, and those vibrations are detected by the machine. If a child fails this, they will have another specialized test, which is called ABR. And this test will show us the brain response to sound. So the first one was ear response to sound, and the second one, brain response to sound. This is a link where you can see a short video about neonatal screening. Neonatal screening, as I said, the first test is done in Gibraltar, but if a child fails the first test, we'll need an ABR, which will be done in the UK. We don't have that facility here in Egypt, at least not yet. So what's going to happen next? I don't know if this happens in Gibraltar, but it happens often or should be happening regularly in the UK, that there is a regular health and development reviews for little children. Is that what happens in Gibraltar as well? Reviews, just regular health and health checks of little children.
Yeah.
Yeah. Okay. Yeah. Okay. So, but these do not include a hearing assessment. Obviously, it's better than nothing, because if the parents are concerned on the speech development, or they think that their baby is not hearing well, so those concerns will be flagged up. Children should get a pre-hearing testing by default, but this doesn't happen, unfortunately, and only some children will be tested for hearing loss, especially the ones that there are some concerns about. But ideally, every child should be tested preschool. And this is because hearing loss can progress over time. And those tests may miss, those neonatal screening tests may miss probably not a severe degree of hearing loss, but a moderate degree of hearing loss that may get worse over time. And children are quite bright, and they may develop other means to communication to compensate the lack of hearing. So I've seen children with remarkable skills that have a quite bad hearing. Even a couple of times, children with hearing loss down to 60 decibel, which is just below the banana, that were engaging with the other children almost with no problems, just because they were relying on other ways of communication, like lip reading, etc. So it should be important to test certain categories of children. Unfortunately, we're not there yet. In Gibraltar, a standard hearing test can be done, which is the adult test basically, can be done from the age of 4, because children can be engaged at that age to do a hearing test because they have to respond to sounds. Basically, they are asked to press the button when they hear the sound. And it depends on the day, because the child can be quite, not willing to cooperate, and therefore, but usually by the age of 4, maybe you require maybe a couple of times, but eventually there will be a reliable hearing test. Below the age of 4, it's more challenging, especially, and maybe a 3.5 quite bright child may cooperate, but otherwise most of these people will have to be sent to the UK, which is a bit of a, how can I put it, a bit sad, because all that would be required in the GHA is to get a second audiologist with specific skills in testing children with testing children's hearing. We have asked several times, but so far this has not happened. And it's, for me, it's difficult to understand, because imagine that at least 40 to 50 children have to go to the UK each year, and some of them will require multiple trips, because one trip may not be enough. And that implies a lot of funding. Not just the child needs to go to London, but also maybe one parent, both parents. So it is a financial burden. But I'm not here to discuss the politics of the GHA. But anyway, so children below the age of 4 will have a hearing assessment in the UK. And still, we don't have any preschool testing, because now, guess what, we'll require a second audiologist. This is just a diagram of what happens if a child has the first test, or the ABR, and those tests show there is some degree of hearing loss. Then they will be referred to further audiological assessment, will be referred to an ENT clinic, and possibly another array of investigation will be done, genetic testing and so on, imaging studies with CT scan and MRI scan, etc. What are the most common causes of sensory neural hearing loss? Aging, noise exposure, infection, hereditary condition, medication, and benign tumors. Can I move? Does it work? No. Now, I just put up this slide because this is the only medical emergency for hearing loss, a sudden onset hearing loss. Usually it's on one side and one side only, all right? Because a sudden onset hearing loss, sensory neural hearing loss, not conductive, sensory neural, so the snail is suffering basically, is a medical emergency that needs to be diagnosed first and then treated. So if you happen to have, wake up one morning with quite a significant reduction in your hearing, or you can hear anything on one ear, then I wouldn't wait more than 24 hours and then see your doctor, and your doctor will refer you to either the audiology department for hearing assessment, or most commonly to ENT, and we will do also the hearing test. Because study has shown that steroids can facilitate the recovery. 50% of people that have a sudden onset hearing loss of the sensory neural type will recover. But with steroids, that number goes up to 70–80%. So you wanna, it's like flipping a coin. If you don't take any drugs, if you take steroids, it's likely there will be some recovery. Okay, so again, sensory neural hearing loss, you saw this diagram before, and this is a normal hearing. No need to spend more words on this. All right, noise-induced hearing loss, we'll touch on this, is the second most common cause. It's both occupational and recreational. Usually the harmful number is 85 decibel. So exposure 85 decibel for more than 8 hours will require hearing protection with ear defenders. Right, noise exposure. This just want to show you that it's a bit different from the age-related hearing loss. You can see this dip here at high frequency, and this is a typical diagram of somebody with noise exposure hearing loss. Now, there are several studies have linked dementia to hearing loss, specifically the Johns Hopkins study that has showed that hearing aid reduced the prevalence of dementia of 30%. And furthermore, older adults with greater severity of hearing loss were more likely to have dementia. Okay? So there is a link between the two. Oh, too many. Conductive hearing loss, glue ears, infections, wax and foreign body in the ear canal, damage to the eardrum, hereditary condition that may affect the little bones that transmit the sound, like otosclerosis, and as I said, traumas as well. Wax, there you go. Got some wax, and this is how we remove it in the clinic, either with a little suction device and sometimes with other instruments. A lot of kids put a lot of stuff in the ears and the nose, so this is probably some bead that a child put in the ear. This is an insect. One day I woke up, there was something that was crawling on my eardrum, it was an ant, so I drowned it with some water. Something you can do. And sometimes we have to remove this, not very often, but in children, foreign body in children are more common. Otitis externis infection of the ear canal can be quite painful with discharge. So pain and discharge are the typical symptoms, usually the smelly discharge of this condition. Luckily, it doesn't last more than a few days, but it can be a quite intensive pain. Let's see if I move this closer, maybe. This is glue ear, as I mentioned before, is a buildup of fluid in the middle ear. So the sound, in order to travel and to get to this thing, has to go underwater as well. So that causes a reduction of the, impairs the transmission of the sound. Sometimes this may lead to infection with perforation of the eardrum and recurrent infection. And the treatment of that is drops, antibiotic drops, and sometimes grommets in children, which is a little ventilation tube that helps to ventilate and drain and dry the middle ear. Normal eardrum, hole in the eardrum. Okay? It's a large hole of the eardrum. Usually doesn't cause a great degree of hearing loss, but occasionally patient can complain of a significant reduction of the hearing. That's another hole in the eardrum. This is a picture of somebody with a chronic infections that keeps coming back, and sometimes if it's not responsive to treatment, medical treatment, needs to be dealt surgically to clean the middle ear of the disease. This is the genetic condition like I mentioned before, which is a relatively common cause of hearing loss. Is due to bone malformation, which stiffens the movement of the stirrup, and therefore the sound is not conducted as well as it was before. Although it's a hereditary condition, it tends to present during adulthood, between 25 and 35 years usually, and it slowly tends to progress. Treatment for this is hearing aids, guess what? Hearing aids, and sometimes surgery to replace the stirrup with a synthetic piston. So what are the management options for hearing rehabilitation? For hearing rehabilitation? Well, there are different types of hearing technology. Hearing aids, we'll touch about this. And if the hearing is too severe and patient are not helped by hearing aids, then cochlear implants and middle ear implants are an option. Sign language, obviously, as Richard is a living example, is quite useful as well. And also there are other types of rehabilitative therapy to enhance the communication skills, but those are the main ones: hearing aids, cochlear implant, and middle ear implants. This is just the main ones. I'm not going to many other details, otherwise it will be here till tomorrow morning. All right, so this hearing aid wise, we go from the first experiment, like this black and white picture shows, to other more sophisticated types of hearing aids. The first one were behind the ear. Now we also have in the ear, in the canal, hearing aids. Generally, the smaller the hearing aid, the less powerful and more delicate and fiddly to use and to be removed, generally speaking. So these are some of the types: the behind the ear, in the ear, and in the canal. The behind the ear are the ones that can address all types of hearing loss, from mild to profound, and the small ones are more specifically targeted for mild to moderate hearing loss. These are the ones that are available in the NHS and the GHA. The behind the ear, these are basic entry models, but can be quite useful. They don't have the possibility to equalize the sound. So this is something that requires more advanced hearing aids, like the ones that are can be purchased in the private sector. The catalog is usually updated on a yearly basis, so you will never be offered an obsolete hearing aid by the public system. And then Eugenio can give you some more information. There's a larger selection of the private hearing aids. They have a digital receiver which improves the quality of sound. They have a smart system that allows to tune in and out the sound to eliminate background noises. And most of them are fitted with a Bluetooth, so that can be used to stream directly calls, can be connected to TV, and so on. Another advantage is that they are rechargeable, not like the others. They have a battery, rechargeable, so you can leave them on the dock overnight and they will be charged and ready to be used the next day. Cochlear implants is an alternative to hearing aids in the presence of severe or profound hearing loss and poor speech discrimination. There are specific criteria for that, and they are more useful in patients that have already learned to hear. What I mean by that, for example, a child that has a significant degree of hearing loss, but regardless of that, was able to develop his speech or her speech, and eventually the hearing got worse and worse, and the hearing aids were not helping anymore. But the brain has a memory of the sounds and of the words, so these are candidates that do better compared to what we call prelingual, the ones that didn't learn to speak, and those do worse, especially if many years pass by between the diagnosis of profound hearing loss till the time that they're assessed for a cochlear implant. Basically, an electrode is inserted into this nail and connected to processor that are attached in the back of the ear. Middle ear implants. We have a member in the audience that has one. Can you stand up for us?
Hi.
Can you come over here for a sec? All right. Oh, okay. Let's. I'm the journalist. What's your name?
It's Louis.
What do you have?
What, sorry?
What do you have in your ear?
I have two cochlear bone conduction implants.
Okay. So these are the bone conduction implants that are attached to one of the ossicles. There are little bones in the middle ear. Okay. And what they do, they cause vibration, And by doing so, they stimulate the snail to respond to sound. What is the difference that you found between the conventional hearing aids and the ones that you have now?
The roboticness of it is, there is no robotic sound at all comparing to the normal hearing aids.
So the normal hearing aids give you some robotic sound, or the other way around?
No, no, that's not what I meant. What I meant is the hearing aids in my case didn't work because my problem is the conductive hearing loss, and the difference is that I can hear more clearly.
Okay.
Basically.
So you find them useful?
Very useful.
Okay. Many thanks.
Thank you.
Research-wise, the scientists have focused on 3 different roads towards the solution of this problem. One is genetic, one is cellular, one is pharmacological. What do I mean by that? Those cells that patients with hearing loss have lost or have been damaged cannot be replaced, as we said before. But what about the future? What if we were able to regenerate or implant new cells or bring into the snail modified genes that can promote regeneration or can fix those damaged cells? Well, this is what is happening in the research at the moment, and they are promising studies that not tomorrow and not in 1 week time, but hopefully within the next few years there will be some breakthrough that will help people, especially with age-related hearing loss, that have lost those cells, to hear better. And also there's been some research regarding drugs that can help to protect and restore the hearing function of some of those cells. So basically, just to sum it up, it's early identification of the hearing loss and the cause of the hearing loss is crucial. And early intervention is critical to successful rehabilitation outcomes in patients with hearing loss, as delays can have a negative impact on language development, communication, cognition, and overall the well-being. A lot has been done, but a lot can still be done, and we as a community and doing what we're doing now, sharing the awareness, can also help to improve in the community the awareness of hearing loss, and therefore this will hopefully will reduce the interval of time between recognizing the problem and managing and addressing it. Last but not least, a few questions to see whether you were listening. That's the last one, okay? Then you can go and sleep or have a drink and forget about this lecture. What are the 2 types of hearing loss? Anybody can volunteer? Okay, I'll give you one. Conductive. Sensory hearing loss, very good. The most common 2 causes in adults of hearing loss? Age-related? Occupational, yes, very good. Most common cause of hearing loss in children? Congenital. How many children have severe hearing loss over 1,000? 1. Good. You did very well. You make me proud. What has a keyboard structure? The snail, which is also called the cochlea. Very good. So you got 1, 2, 3, 4, 5 so far. Now, come on, you can do it all the way down. Grommets are useful for? Yeah, for glue ear, ventilated middle ear. Very good. Harmful, that's more difficult. Harmful noise level, I told you only once. 85, yes. Last but not least. Come on, you can do it. Treatment of sudden sensory neural hearing loss. Excellent. Applause to the audience. All right. Thank you very much for coming.